All right, we can go ahead and begin. Welcome everyone to today's shadowing session with Dr. Harry Liu. He's a dermatologist, so thank you so much for joining us today.
Thank you for the introduction. Okay, so hopefully everyone can hear me okay. So hi everyone, my name is Harry. You guys can call me Harry. I'm a third-year dermatology resident, and I'm based in Vancouver, Canada, and I'm doing my residency program at the University of British Columbia. So the goal for today's session is to give you guys some insight into the specialty of dermatology, because when I was pre-med, I was thinking I was going to medicine. However, once you're in medicine, and then when you're a medical student, and then you have the pressure kind of like figure out what specialty you like. And then we always can end up being like a special kind of doctor, not just like being a doctor. So it's good to have different perspectives before getting to medical school, kind of have a good idea what different specialties look like, because many specialties demand different skills, and then many specialty can have different traits for people. So it's good to have more exposure. So my goal for today is gonna do a bit of an introduction of myself, and then share with you guys my journey to dermatology. And I'm also going to talk about dermatology in general. And I'm going to talk about some case studies, some typical cases we saw in clinic, at hospital, so you guys have idea kind of what kind of patient we see. And then lastly, we're going to go over all the questions you guys have. So feel free to like type in a question in the chat box, and then we can go over them as we go, and then also at the end. Okay, so for introduction, so I'm actually in my third year of residency program, and then it's a bit different in Canada, because in Canada it's a 5-year specialty. In the States, it's more like a 4-year specialty. And then this is all the faculties we have at our university. You can see it's quite diverse. And at the front is all the faculty members. We have like in the middle, we have the board certified. He's the department head. He's a both dermatologist and also a dermatologist. And then many of them are pediatric dermatologists, Mohs surgeons, and at the back are the residents. I am actually here. If you guys interested, looking for me, I'm here. Okay, and then going back a little bit, and then like I think most people started with undergrad, and then like why was pre-med? I did my degree in biochemistry at McGill University in Montreal, Quebec. And I only did 3 years because I did IB prior and got some credit transferred to the university. So looking back, and then my advice for you guys is like, you can basically do any kind of undergrad you want. And then in medical school, we have people did math, people did physics, people did like music, people did like law school before. So it's actually quite diverse, and all the skills can be transferred into medicine. So definitely most people do a science degrees, and then don't be afraid to take any kind of other courses if you want, any like arts courses, because as we're gonna tell, like in certain specialties like dermatology, plastic surgeries, and have a good visual skills, have like good like those are quite essential for you to be good at those specialties. And then moving a bit further, and I went to U of A, University of Alberta, and for my medical school. And then this is my medical school graduating photos. And then as I told you before, like medical school is kind of like going back to high school, and then you like hang out with the same people, you're having like fixed schedules with most people, and then you really get to like make friends for the rest of your life, not only friends, and also colleagues at the same time. And then like many of them have very diverse background educationally, also like they have different hobbies, and then you'll be able to meet really interesting and really talented group of people. And I moved away from Montreal to go to Alberta because I do want to explore different parts of Canada. At the same time, I want to like step out of my comfort zone. And if you're down the road, if you guys want to pick kind of like, oh, should I stay home or should I go away for like my medical school? Definitely going away has its own like pros. And then you can make new connections and you can explore new cities. I'm really glad I was able to do my medical school at a different place. And then right now I'm in residency, which is in another new location. So I was able to make connections with people from different parts of Canada. So it's another good thing about exploring different places for your educational journey. So for my personal interests, I have quite a few interests. First one, I really interest in medical education. So I made a lot of podcasts for like a medical student on different dermatologic conditions. If you guys interested, this is a really good website, www.peacecases.com, and it has lots of interactive podcasts. If you guys interested in pediatrics, learning more about like kids, children, and it's a good place for you guys to visit. And then the second thing I'm really interested in resource stewardship in medicine, because the differences in Canada versus the States is we have universal healthcare coverage in Canada. So like physicians are really the person who like guard for like deciding if the test is necessary. So I'm really interested in stewardship. For example, things like unnecessary medication, unnecessary imaging studies for the patient, because many of the medication, many of the imaging studies do have its side effects. And then my goal was to make sure the patient got the right intervention, got the right medication to minimize side effects. And then in my own time, I'm also interested in coaching. I have been helping a lot of medical students and then like dental student or pharmacy student to get into medical school. I mostly just help them like how to best portray themselves during the interview setting so they can overcome their barrier to get into medical school. Okay, and the last part, that's about myself. I'm just gonna quickly go over to see if there's any questions. We have quite a bit of questions here. And some of them I'm gonna talk about later on. And then, yeah, I think most of the questions I'm gonna cover later on. So stay tuned, okay? Yeah, perfect. So we're gonna talk about dermatology right now as a part 2 of the talk. So this is a question for you guys. You can think about it. So which of the following patient may not be referred to see a dermatologist? So A, it's a 35-year-old pregnant female with a blistering rash. And then number 2, a 10-year-old boy with diffuse hair loss and it was isolated at school. Number C, an infant with multiple painful oral ulcers that could not feed. D, an 80-year-old man with a dark brown colored band on his nail. E, a 50-year-old woman with significant itch and becomes suicidal. F, a 25-year-old man with significant sweating and needing to change clothes every hour. Okay, I'll give you guys a few seconds to think about which of the patient may not be referred to see a dermatologist. Okay, so this is actually a trick question. So the answer is like all of them will be referred to see a dermatologist. So the reason I want to do this question is because it's really emphasized and then it's not just about the skin. And then we see patients, because we own the organ as a dermatologist, we end up seeing patients from newborn all the way to the elderly. And then in addition to skin, we also see like oral mucosa, we also see hair issues, nail issues, or even some condition you cannot see visually. For example, like pruritus, which means itch, and also hyperhidrosis, which means lots of sweating. And also it's really a very broad specialties, and you get to see a lot of, you'll get to see a wide range of patient group. As compared to many other specialties, for example, pediatrics, you're only gonna see kids. For obstetrics, gynecology, you're only gonna see mostly like women. And then for internal medicine, most of the patients are gonna be 50 plus because those are the patients who have multiple comorbidities. And then so dermatologist is quite unique from that perspective. And I do really enjoy kind of like seeing different kinds of pathology, seeing different kinds of patient every day, because first hour, like first patient can be a kid, second patient can be a pregnant woman, third patient can be elderly. So that's actually quite diverse from my perspective. And then the other thing is, once you're in medicine, people are gonna be asking you, do you wanna be like doing medicine, or do you wanna do surgery? So in terms of the dermatology, you actually get to do both. You got to be a thinker and also a doer. So from the thinking perspective, because dermatology, we own the organ, and then different pathology can happen on the skin. So we end up seeing things like oncology, we see like different kinds of skin cancers, we see infectious disease issues, we see like bacterial infections, fungal infection, viral infections. We also see allergy issues like urticaria, which means hives, and allergic contact dermatitis, like drug reaction. We also see rheumatologic issues is basically joint issues, people with connective tissue disease in the case of lupus, vasculitis, and all other kinds of connective tissue disease. We even see like pathology because we spend a lot of time learning pathology as a resident, as a dermatology resident, because skin is so accessible. We do biopsy quite a lot. So we need to understand when we get a report from the pathology, what does the pathology mean? So we do lots of pathology. Or even things like psychiatry, people like bite their nails, like pull their hairs, and it's actually quite common. It's underappreciated, and then we sometimes also see see some psychiatric patient as well. So just to give you some visual representation of kind of some of the condition. So the first one is a black lesion that's suspicious for melanoma. And then the second case, you can see the kind of like zigzagging, serpiginous, like a snake pattern. This is actually cutaneous lava migrans, basically lava of a parasite crawling underneath the skin. And then the third one is we call dermatographism. It's basically people get hives with physical pressure. This patient was scratching the skin. You can see the gets hives right after. And then the last one is a patient with cutaneous lupus. And the lupus is this disease that can impact any organ, including the skin as well. So that's the thinking aspect. And then moving on to the doing aspect. So, just continue with the thinking actually. So besides, because the skin is so accessible, so we give lots of topical treatments, and then people make jokes like, oh, dermatologists can only prescribe like topical corticosteroids. But that's not the truth, because we do offer a lot of systemic medication, basically injection medication, take by pills, things like antibiotics, antifungals, antiparasitics will give really strong anti-immunosuppressants, because many of the conditions are inflammatory because the immune system are too strong. And then we even give like biologics, which is a protein we inject into people's body by injection or by infusion to help with some of the inflammatory conditions. We even do like phototherapy, give patient light to reduce the inflammation. For example, in the picture you can see on the left side is a patient with psoriasis. You can imagine this can be very traumatic to the patient, can really impact their quality of life. And the psoriasis can involve their genital regions, it can involve their face, can involve their scalps, can involve their hands. So patients are usually very, has lots of stigma around the condition. And then you can give patient phototherapy, which is on the right side. Basically, patient going to this booth, and I would give them like a part of the UV light to reduce the inflammation. And in other cases, we can even give patient like biologics I mentioned before, which is injection medication. And then patient can have their skin completely cleared after several weeks, after a few months. And then you can imagine how appreciative the patient will be when they come back to see you, okay? And then moving along to the doing aspect. So besides the thinking, dermatologists do a lot of procedures. For example, like biopsies, which means taking samples from the skin, laser therapies, cryotherapies, which is liquid nitrogen, and then different kinds of flaps. And then flaps means when you take out part of the skin, you want to cover the skin with the other part of the body. So that's flaps. And we also do electrosurgeries, use electricities to cut off skin cancers. We also do a specialized Mohs surgeries, which is you take out the samples and you look under the microscope right after. And then you basically have to do the work of a surgeon and then the pathologist. Okay, and then just some pictures here. So the first picture is a child with port wine stain, which is a vessel, which is like a malformation of the vessels. And then like with laser therapy, and then the spot can be completely cured, as you can see in the photos. You can imagine how happy the parents gonna be when they see the improvement. And in the middle, it's what we call cryotherapy. Basically, you treat patients' skin conditions with liquid nitrogen. And then on the right side, and then it's basically a patient has skin cancer. And then you can imagine we took out the skin cancer, and then you can sew them from left to right. However, that can deviate the nose, okay? So that's why we need to design and then flap to make sure the patient had the best cosmesis down the road. So that's why we do those flaps in order to maintain the cosmesis. And you can see in the last photo, and then the outcome is actually pretty good. And then many times you can hide the scar pretty well with the with known skin lines. And then patient end up being very happy coming back to see you, okay? And then the other thing is like logistics aspect of the specialties. So dermatology, as you can see, is a specialty with pretty balanced in terms of gender, like 50% female, 50% male in Canada. And in the States, it's quite similar. And in terms of the age group, it's quite balanced as well. And then most people actually end up practice in a clinic. And then the clinic's actually quite fast paced. And then because it's a visual specialty, you diagnose with your eyes, and then can usually able to diagnose the patient's skin condition pretty quickly. And then in Canada, and then a typical community dermatologist sees like 50 patients, 40 patients daily. And in the States, a bit less. And then you can only, at the same time, you can only see consults, which is basically patient admitted to the hospital, and then they have some skin conditions, and then you go see as a consultant, okay? And then the other thing is, being a dermatologist, a unique thing is you have to learn a lot of different conditions. For other specialties, you need to know a few conditions really well. However, for dermatologists, because skin is so big, the organ is such a big organ, and we end up studying a lot of different conditions in dermatology. And dermatology is one of the specialties that involve lots of reading around different kind of like subjects. And last one is, hopefully you can appreciate, based on what I told you so far, dermatology is actually quite diverse. So diversity means flexibilities. When you finish residency, when you finish your training, you can find your own area of interest. You can decide the portion of medicine versus surgery, how much you want for medicine, how much you want for surgery. And you also can determine how much you want for clinics and how much you want for hospital medicine. So that's the flexibility you can have as a dermatologist. And as you can see in the figure on the right side, the corner, right, lower corner. And then it's quite diverse for most people. And however, significant proportion of people is actually doing clinic-based medicine. And then the other thing is, when you think of different specialties, and it's important to think about how happy they are, because medicine is a very demanding specialty. And then you want to pick a specialty, you can enjoy your life, and then you can be a happy whatever you become, okay? So this is a survey actually from the States. And in 2020, they surveyed a bunch of physicians in different specialties. They asked them, would you pick the same specialty again, okay? And then as you can see, like the top ones, like orthopedics, oncology, ophthalmology, dermatology, plastic surgeries. And then I'm not saying that's one reason why they pick the specialties. However, the common theme among those specialties is they improve people's quality of life. For example, orthopedic surgeons are the ones who fix people's joint. A hip replacement surgery, people can walk again, right? And then for oncology, and then if someone being referred to oncology, they usually have end-stage disease, means like their life expectancy is shorter. However, the job of oncologist, they actually can improve their people's quality of life when the ultimate goal of the treatment is not to prolong life. Okay, and ophthalmology, I mean, it may not die from losing vision. However, having vision is very important for people's quality of life. So is dermatologist. So when I was a medical student, I rarely see any unhappy dermatologist, and that means to me it's a great specialty. And then there are many reasons for that. Okay, and then so going to some of the reasons people may make people happy in dermatologist, or some of the reason for you to consider dermatologist down the road is number one, already mentioned. And then dermatologists are happy with their choice. And the second thing is dermatologist has a really good job prospect. There's a significant shortage of dermatologists, both in Canada and also in the States. And then you can easily find a job in like urban setting, like in urban Vancouver, or in like big urban centers in the States. And the third thing is fellowship, because for many of the specialties, like for example, most of the surgical specialties, you have to do more training after you finish your residency, and then in order to get a job. However, for dermatology, fellowship is available, okay? However, it's not mandatory for you to get a job. And the options include pediatric dermatology, Mohs surgeries, rheumatology, laser, and cosmetics. And it's usually 1 year. And in Canada, there's Vancouver and Toronto have programs, and then many of the in the States, many of the big centers have the fellowship programs as well. Okay, so let me just check. Is any question? Okay, so what is there's some questions in the chat box. The first question is people ask, what is Mohs surgery useful for? And then is it for diagnosing cancer? Okay, so Mohs surgery is a specialized surgery and then to treat skin cancer. So if someone undergoing Mohs surgery, that means they already had skin cancer diagnosed. The benefit of having a Mohs surgery is because we cut out least amount of tissues. First of all, that's one of the most important reason, because for other surgery, like just blind, like for like other kind of surgery, and then you don't know where the disease is. You only look with your eyes to decide, okay, this is the cancer, I'm gonna cut out this part. However, for most surgeries, we cut and then we look under microscope. So we're able to cut least amount of tissues. And then imagine a place on face, right? For example, imagine it's over the eyelid. And then most surgeries can actually have a better cosmesis at the end because you cut out least amount of tissue. That's one reason. And then the other reason is because when we cut out the spot from Mohs surgery, we look under microscope 34 or like 360 degree. So we're able to cut out more cancers at the same time and have a better outcome for the patient. So those are the main reasons, okay? And the second question people ask, is lupus an autoimmune disease? That's correct, because you guys probably watch like House, right? And then the most common one is lupus, like that's for the diagnosis, because lupus is autoimmune conditions. Basically, your body produce immune cells, attack different parts of the body. And that's why lupus is a good mimicker, because lupus can attack the brain, and then people can present to a psychiatrist. Lupus can attack the eyes. Lupus can attack the kidney. Lupus can attack the skin at the same time. So can give you a wide presentation. And then so that's why lupus can be challenging initially to be diagnosed. And then so that's the answer to your question. Okay. I think that's all the questions we have so far. Okay. Yeah. And the other question we have is, is there a work-life balance in dermatology residency? Okay. So I think in terms of residency for all specialties can be challenging because you need to learn a lot of information. At the same time, your working hours may not be different when you become a practicing physician. So for dermatologists as a different kinds of busy, okay? So we're not on call a lot compared with many other surgical specialties. And then because we don't admit patients to the hospitals most of the time, we are consultant. Basically, the patients admitted under other specialties, and then we go there, give advice for their skin. We don't necessarily have to manage like their discharge. We don't have to manage their like other issues necessarily. And then, however, the challenging part for dermatology is it's a very book knowledge heavy specialties because there are 2,000 conditions we have to learn as a become a board certified dermatologist. So many of the conditions we don't see actually in residency. So as part of the residency program, so we have to study a lot. So that's part of the kind of like work balance. But personally, I do feel like compared to other specialties, I do have more balance of my time because I can decide like when to read. I can decide like when I want to like enjoy my hobbies, when I want to do research. So from that perspective, it's a bit more flexible. Okay, we're gonna move on, do some cases that can be interesting. Hopefully, oh, sorry, we forgot the slides. Okay, so at this point, you probably know, oh, dermatology is great, and there's such a wonderful specialties, and is that gonna be a good fit for me? Okay, I'm gonna give you some of the insight for yourself to decide if this is something gonna be a good fit for you. So first thing is, dermatology is a very visual specialties. So basically you diagnose with your eyes. So you have to be detail oriented. For example, the rash I showed you here, first of all, you want to know they're different, they look different, right? And then you should be able to interested in looking at the color, looking at the shape, looking at the like the border, look at the texture to be able to make the diagnosis. So you need to pay attention to the details. And then the third thing is, like many of the skin conditions have underlying internal organ manifestation, internal organ issues. So you have to have strong interest in medicine, not just surgery. And the last thing is there's a lot of learning involved, self-directed learning. So you have to be okay with like reading a lot, memorizing lots of information, right? So that's, if you're kind of person, I just want to kind of like do the surgery, do more like hands-on stuff. So dermatology may not be the best fit for you, or the most surgery part can be a best fit for you. Okay, just to give you examples with this photo. So first of all, when looking at the photos, we are diagnosing with our eyes, right? And then secondly, you want to make sure you pay attention to the details, appreciate for this patient, there are two different kinds of spots going on, right? So on the right side, we have more like black colored, more like smaller, more discrete, those lesions, like those spots, right? And on the other side, the color is more yellow, right? And then so in order to pay attention to the details, you're able to diagnose this condition, which is this name, and then you have to memorize the name, right? And then the other thing is, more importantly, for this kind of patient, they can have increased risk of underlying cancer. So you want to refer the patient to like oncologists, to other specialists to able to manage the patient. So this is if you feel like, oh, this is something interesting, your dermatology may be a great fit for you down the road. Okay. And then it's quite rewarding when no one knows what's going on with the patient, and then the patient finally come to see you, and then you're able to make the diagnosis by simply looking at the rash, right? So that can be you feel like you are the Dr. House sometimes, right? And we're gonna move on to do some case studies, and then just talk about kind of like cases we see in dermatology residency program. Okay, so first of all, like dermatology is a very visual specialties. Okay, so like we all perceive our world with our eyes. Okay, for example, you know this is apple because you see apple so many times. Okay, however, I'm gonna break them down into why you think this is apple. Okay, because for this case, if you're not seeing the picture, if someone has to describe it, they probably say like on a round table, there's one red circular shiny object with a small imagination on top, and it measures 7 centimeters and casts a shadow, right? So that's how, if someone never seen an apple before, this is how you describe to them, right? And then you based on location, number, color, shape, texture, and the size to help you decide this is an apple. Okay, so for the next few slides, I'm gonna tell you how you can diagnose the skin conditions based on those parameters. Okay. So the first one's location, okay? Certain conditions happen on specific body location, and a similar rash on different location can pointing towards different diagnoses, okay? So this condition is called keratosis pilaris, quote unquote, chicken skin. It's a very common condition. It's happened at the posterior, at the back of the arms. And then sometimes can happen on the cheeks, sometimes can happen on the side of the thigh. It's extremely common. It's genetic. and then it's autosomal dominant, and then if you have it, and then sometimes your parents may have it. Okay, so just check out your skin right now. You may have this condition. You may not know. You may not notice. Well, pay attention to like other people in the summertime. People have those bumps like on the back of their arms, and then this is keratosis pilaris. And then if you telling me someone has like bumps over the back of the arms, over the side of the thighs, without kind of like thinking, most likely this is this condition called keratosis pilaris. It's basically your hair follicles, and then around hair follicle, there's kind of the dead skin, right? Just because we shed our skin. However, for patient with this condition, and then the hair follicle have the tendency to retain the scales. Okay, so that's why it looks like more bumpy. It looks like a chicken skin. Okay, so that's the location. And then in terms of yeah, and then in terms of number, and then so sometimes the one solitary means like one, lesion means like a medical term for the spot. Okay, so solitary lesion versus multiple lesions sometimes can be helpful, because if it's only one spot, that's more possible. It's more malignancy / cancer. Rather, if you have multiple black spots, it's less likely to be a skin cancer, right? And then also color. So in terms of color, and can actually tell you what the underlying causes, okay, and then what kind of cells are involved in the rash. And then to give you some examples, okay, so first one, you can see this is more like yellow, right? Yellow. So if you think about yellow, what is yellow in the body? It's probably fat, right? So the first condition is this is actually fat deposition around the eyelid. And the second one is, and the second picture, this is red, right? What is red in your body? Blood is red. So this is some sort of vessel proliferation, and looks red is because it's blood inside. And then last one is black. When you think of black, you think of like melanoma, like moles, those things, right? So that just shows kind of like color is really helpful. So the first condition is called xanthelasma. It's basically if someone have increased fat or increased cholesterol, increased lipids in their body, they can have their skin findings. And the second thing is called cherry. That's a typo. That should be cherry angioma. Is basically a benign growing of the blood vessels. It's very, very common. If you check your parents today, they may have it, okay? And the last one is we call melanoma. The reason it's not a normal mole or like a normal nevus is because it's quite irregular, right? The colors, the different colors, the red, there is black, there's brown, right? And it's not symmetric. And then one side is look very different than the other side. And then the border is kind of like ragged, like irregular border. So these all the features make you think this could be a melanoma. Okay. And then and moving on, the next thing is actually we call shape. We diagnose the rash based on the shapes. Is it a circular? Is it round? Is it polycyclic, multiple circles? Is it linear? Is it symmetric, right? And is it geometric? Geometric, I meant, like what I meant by that is sharp angles, sharp lines. Like human body does not produce those like perfect triangle, right? It doesn't produce a perfect square. If you see anything geometric, you can think of outside jobs, because skin will get exposed to the outside world, and then there are many times, and then you can tell like what the patient is going through by looking at this, by looking at their skin. To give you some examples, right? So the first one is as I talked before, when you think of black things, think about mole, melanoma. However, for this one, it's very round, right? Perfectly round, perfectly symmetric, with only one color. So that makes you think this is not as concerning as the last one. And then the second one is multiple circles, right? Multiple circles, and then we call polycyclic, right? And then this make you think of ringworm, right? Ringworm is like a ring, and then the it's caused by a fungal infection, and then the fungus kind of infected the skin, and then the fungus keep growing, and then make a bigger and bigger circle. And then the most prominent part of the fungi is actually at the border, because they kind of like migrating like outside as they infecting the skin. And the last one's kind of linear. There's some blisters around. Actually, as I told you before, like we like as a human, our body never really make anything that's perfectly linear, right? So if you think of something that's linear, think about outside jobs, right? So just review the diagnosis. The first one is we call congenital melanocytic nevus, which is a medical term for mole. And the second one is a medical term for ringworm, which is called tinea infection. And last one is a poison ivy dermatitis. It's basically this patient went hiking and then they get in contact with poison ivy, and then like it's basically the leaf cutting the skin, contacting the skin, make those sharp lines. Okay, so this is some of the examples that the shape of the rash can help you make the diagnosis. Last but not least is actually the texture. Okay, so the texture, it can be associated with secondary lesion, basically means what happened after the initial rash. Okay, it can be scaly, it can be wrinkly, it can be smooth, it can be pearly. Just give you some examples. The first one, as you can see, the texture we can appreciate is quite scaly, right? Lots of scale, lots of shedding. And then the second one, if you have this describe it, it's kind of pearly, looks like a pearl, as you can see in the photo here, right? And then the last one is kind of like a lot of wrinkling on one side of the face, right? So this is a texture. So by knowing those kind of like texture change, it can actually help you make the diagnosis. The first one, the classic picture of psoriasis, those like thick white rash over the elbows, over the knees is classic for psoriasis. As I showed you before earlier, if you remember, and then those like white rash over the back of the patient with a phototherapy photo, those are classic for psoriasis. And the second one is the most common type of skin cancer called basal cell carcinoma, which is the classic pearly texture with kind of blood vessels, overlying blood vessels. And then the last picture is a medical term the medical term is dermatologist, which means consequence of sun damage, okay, cause of sprinkling. This person is a bus driver. So one side of the face is exposed to the sun and not the other side of the face, okay? So this can demonstrate how much sun damage how much sun can actually cause wrinkling, atrophy of the skin. Okay, there's just some of examples like kind of going into the head of dermatologists, right? Because as I told you before, you guys see the apple right away, you know this is apple. So for example, when you guys are shadowing, you see a dermatologist. Oh, they see the patient, they know right after, without patient even speaking, this is this diagnosis. This is how dermatologists make the diagnosis. If you feel like this is quite interesting, this kind of process, and then dermatology may be a good fit for you. And then even other specialty things like ophthalmology, like eye doctor, pathology, right? Radiologist, or they all diagnose with their eyes. If you really kind of want to use your visual skills to be part of your future career, those are the specialty you should consider. And then when you in medicine, okay? And then that's pretty much what I have prepared for today. And then I do want to leave some time for questions. And then so to have more like a conversation, because I have been talking quite a lot. Make sure this is more audience specific. Let me just quickly check if there's any questions we can go over. Okay. And yeah, so we have a question, more like a medical question. The person asked, what's the difference between psoriasis and eczema? So that's a great question. Let's go back a little bit of this chart. Sorry, this chart again, okay? So you'll ask a really good question because both condition can be very similar, okay? Because skin actually is actually quite deep. There are, we call it superficial skin, deep skin, or even subcutaneous, like underneath the skin. If we have like fat, we have blood vessels. So both condition happening in the epidermis, which is like they involve the pathology. If you look under the microscope, both condition is involving what's happening over the superficial aspect of the skin. So they can look very similar, okay? However, how you differentiate them apart, number one, location, okay? So for location-wise, for psoriasis is usually over the elbow, and it can over the scalp, can be over the scalp, can be over the genital regions. However, for eczema is usually on the hand for adult, and then for kids is usually inside the arms, inside the knees. Okay, so location can differentiate. Okay, number not really color wise. The scale is quite different. So the scale in psoriasis is like very thick, very white, and then in eczema, dermatitis is more like yellow, kind of like oozing, okay? And then shape is not a differentiating factor. For psoriasis, like sharply demarcated. You can use your pen to draw around the psoriasis. For eczema, you'll be poorly defined. It's hard for you to appreciate the border where the rash started, okay? And then the texture-wise, as I said earlier, one is very thick, and then the other one's like oozing and then like crusted yellow. So those are the differentiating factors, okay? However, if you know the image, if you know those parameters pretty well down the road, and then you'll be able to walk into a room and then tell the patient, oh, you have psoriasis, you have eczema. However, sometimes it can be challenging to differentiate. That's why we have the tool of like doing the biopsy and look under a microscope to differentiate, okay? And then the other question I think from the audience is, do you see a lot of DOs in the field? Okay, so in Canada we don't have DOs, and I think that's mostly in the States. And however, personally, based on my knowledge, there are people who with DOs doing dermatology. So that's completely possible. Okay. And other question is, do you interact with plastic surgeons for post-ops? Okay, so as I said before, going back a little bit, a few slides. So you can decide, given the flexibilities, you can pretty much decide how much surgery you want to do, how much medicine you want to do, right? You can be the dermatologist who don't do any surgeries. You can be a dermatologist we do a lot of surgeries, okay? So for most surgeries, and then like most patient is being managed by most surgeon, which is a dermatologist, and then being followed by dermatologist, by most surgeon post-op. So in that situation, okay? However, for dermatologist who does not do lots of surgeries, and then they usually refer the skin cancer to plastic surgery, and then the plastic surgery remove the lesion, excise the lesion, excise the skin cancer, and then they send the patient back to us. And then we keep following the patient down the road. So that's the difference. It really depends on what kind of practice you want. If you want to do more surgeries, definitely you do a lot of surgery. You can follow the patient. And then, however, we do interact a lot with plastic surgeon colleagues, okay? And the other question is, are you planning to specialize after your residency? How different is dermatology practice in Canada versus the States? Those are great questions. So personally for me right now, I am still quite open because I love a lot of aspects of dermatology. And then like I still have almost 3 years to explore dermatology. And then like things like pediatrics is on my list. And then maybe I haven't done too much Mohs surgeries yet. And then I think like if I did my rotation in Mohs surgeries, that can be another options. However, the good thing is if I like everything at the end of the day, and then, for example, near the end of residency, I can be a general dermatologist. I can see all kinds of conditions, and I'd be having no issues of finding a job, like in Vancouver, if I want to move to the States, if I want to go to California, if I want to go to like Texas. So that's the good things about dermatology. So there's no pressure for me to kind of like figure out if I want to do a fellowship, because compared with many of my colleagues, same year as me, they have the pressure of figuring out like, do you want to do like colon, like fellowship? Do you have to do like endocrine fellowship for other specialties? So that's a good thing about dermatology. And in terms of dermatology practice in Canada versus States, it's actually it's a bit different. And then I actually attended a few kind of like job fair design for like like American dermatologists. I do have some insight. So the major differences in Canada, and then dermatologist is mostly for medical dermatologists, mostly it's paid by the government, okay? And in the States, it's more paid by the patient, and then the fee code is more favorable in the States. Basically means you get paid a bit more to like do like medical dermatology, and then so that impact the patient volume. So in Canada, based on my knowledge, and then most medical dermatology practice, we see lots of patient like 40 and 50, and then patient dermatologists being paid based on how many patients they are seeing. However, in the States, and then it's more like you salary based, and then you end up seeing like less patient. For example, you can see 30 patients a day, or like 20 to 30, and then you getting paid regardless how many patients you are seeing. Okay, so that's the major difference regarding like the pay model. I think the rest is quite similar in terms of the pathology you are seeing. I think both Canada and the States are quite diverse in terms of patient population. And then the other difference is in the States, dermatologists, if you're really interested in pathology, you can actually do 1 year fellowship, and then you can become a dermatopathologist. You can practice both as a dermatologist and a pathologist. Basically, you have the benefit of see the patient in the clinic, cut out the skin, and then check the pathology, look at the skin under a microscope yourself, and then go back to see the patient again. Okay. However, in Canada, and then you cannot practice and without doing a full fellowship, like full pathology, like 5-year program. Okay, well, 4 to 5 year program. So most people do not have the benefit of being like a dermatopathologist and dermatologist. So most people like either do dermatology or they do pathology. So that's another difference between the practice in the States and Canada. However, like derm is very small specialty. Like we hang out, in doing like conferences, we kind of like mingle with residents from the States. I know a lot of dermatologists from the States as well. And it's a very small field. And when you attend conferences, for example, you end up seeing like familiar faces. When you read journal articles, you end up like seeing familiar names you met during conferences. Okay. And then we have more questions. I think another question is, I'm really glad we have lots of medical interest from the audience. And then the other question is, psoriasis and ringworm look similar in shape. And I know both can be itchy and can be scaly. How can you differentiate? Okay, maybe let's go back to the photos a little bit, and then we can talk based on the photo. So for psoriasis, have a mental image of this photo. Okay, first of all, okay, right? This is psoriasis, and then have a mental image of this picture again on the right side. This is psoriasis. Okay, so how you differentiate them? First of all, and then like the shape can be similar, can be both round, circular. However, the difference is for psoriasis, again, you have this thick scales, right? And then for tinea, it's more thin scales. The scales are different, okay? And the location can be different. Tinea can be any part of the body. And then the other thing for psoriasis is because it's a systemic condition. It's what's happening inside your body. So that means the rash will be symmetric usually. It's rare to be on one side of the body. Okay. However, for tinea, because it's infection and infect part of the body, so it can be unilateral, which is basically one side. And then the last thing is for tinea, the classic feature is like the prominent border. That's another very, very diagnostic clue for you to diagnose make the diagnosis of ringworm, because this infection keep going, kind of as they grow, they kind of like growing outwards. And then if you look at those like heated border, prominent border, and look at like a ring, right? And that's kind of like the classic for ringworm. However, in this situation for psoriasis, it's not a ring. It's more like it's more uniform, right? The scale is more uniform in the middle. Okay. And yeah, so I think I answered most of the questions. And then if you guys have, I'm pretty active on Twitter and then on Instagram. I do post lots of medical education stuff, materials for like residents, for medical students, for pre-med students. If you guys interested, you guys can follow me along, and then I'm gonna share more of the content with you guys down the road. Okay.
Sure. Thank you so much. That was very informational. I personally learned a lot. I liked how you really went into like all the different ways to like diagnose the different conditions and everything too. That was really cool. Thank you so much. And for everyone who's still watching, the Google Forms will be open until 8:05 p.m. Eastern Standard Time. So make sure to get that in order to get your shadowing hours. But yeah, thank you so much for joining us today.
Thank you, Akila, for inviting. I think you guys are doing a great job of kind of like given the COVID situation. I think like not everyone has the luxury of shadowing a physician, right? For example, if you have no families families, no connections, can be quite difficult for you to figure out how to become a physician, like those kind of like different specialties. Right. I think you guys are doing something really great.
Thank you so much.
Okay, take care. Okay.
Yep, you too. Bye-bye.
Yeah.